I'm Dr. Kolesnikova.
And I'm Dr. Shakiba.
This is a continuation of our Myths and Misconceptions videos coming to you from women's pelvic surgery.
The purpose of this video is just to add additional information generally to you, and again, this needs to be reviewed by your doctor regarding any medical condition you have.
And today we're going to discuss some common myths, misconceptions that we hear commonly from patients around hysterectomy.
Yeah, there are many. So let's start with number one.
What is a hysterectomy? So when people hear the word hysterectomy, they don't always know what that means in terms of what organs are going to be removed.
In the mind of many people, and our grandma and mother, is when we talk about hysterectomy, they always include removal of everything. And basically removing uterus, cervix, and ovary and tube.
Exactly. So, specifically when we're talking about a hysterectomy, it's what we call a partial or a supracervical hysterectomy versus a total. A supracervical hysterectomy, or a partial, is removing the top part of the uterus, which is leaving the cervix and the vagina. Total hysterectomy means removing the uterus, which includes the body of the uterus and then the cervix. It does not mean removing the ovaries.
Yeah, it is important to understand that even total hysterectomy does not mean removal of the ovary. So if we remove the ovary, what do we call that?
We call that with a bilateral oophorectomy.
And if we remove tube and ovary, which is usually when we remove ovary, we remove the tube as well, called salpingo-oophorectomy.
So there's a lot of discussion around doing a partial hysterectomy or a total hysterectomy, which in one you're keeping the cervix and the other one you're removing the entire uterus. So do you prefer one over the other, a partial versus a total?
Yes, I actually do. When I started 15-20 years ago, I started doing laparoscopy and robotic surgery. And doing it laparoscopically is a little more challenging. So I was very proud. I'm always doing total, removing cervix. And but in the past, I would say 10 years, gradually I started leaning more toward preserving the cervix. And based on my experience, I noted there is really no need to remove the cervix other than having trouble of doing pap smear every year, or in case of any cancer in the uterus, ovary, or the cervix. That's a totally different issue, and we are not cancer specialists, so I will refer that to our GYN oncologist college. And again, on those cases, I know for a fact that cervix need to be removed, so there is no even debate here. But for the benign condition, if the cervix has no issues, if I have an indication to do hysterectomy, I personally like to keep the cervix. I believe and makes sense that in the long term, a patient with total hysterectomy may have lower quality of sexual life compared to supracervical. And the reason is less blood flow, higher risk of vaginal atrophy, and some superficial damage to the surrounding nerve. And I see that in my practice that patient with total is more common to come with dyspareunia or pain with intercourse or dysfunctional sexual life compared to the patient who have supracervical. The fact is, on supracervical, you leave everything intact anyway, so there's nothing to worry about. But on the total, there is some intervention done on that.
From an anatomical point, supracervical just makes more sense. You're not changing anatomy, you're not shortening the vagina. So,
what is the route and method of doing hysterectomy?
So there's different ways that a hysterectomy can be performed. Classically, it was abdominal or an open hysterectomy where you made a large incision, usually an up and down incision, and took out the uterus that way. There's also a vaginal hysterectomy, which means going through the vagina and doing the whole surgery through that natural, vaginal opening and removing the uterus, if needed, the tubes and the ovaries that way. And then more advanced techniques that we have now is a laparoscopy or robotic assisted, which is again going through the belly, but not making that big open incision, just making small incisions in the abdomen and doing surgery in this way.
Yeah, so the minimally invasive approach, which is robotic or laparoscopy, is really changed the way of doing hysterectomy compared to old day, and make the recovery time and the complication rate significantly less. Comparing apple with apple, I would say if it's experienced surgeon doing it laparoscopically versus experienced surgeon doing it open, the laparoscopy or robotic approach have clearly less blood loss and faster recovery, and our average hospital stay would be probably either same day or next day. I would say 99% of our patients are
less than 24 hours.
Less than 24 hours. So all day hysterectomy was 2 to 3 days hospital stay. So that's why back in the mind of many people, hysterectomy is a big deal of surgery, versus on many cases it could be with the right technique and minimally invasive is transforming to a same day type of surgery. It's like almost at the same level of doing gallbladder remove.
Yeah, and with the approach to hysterectomy, we were always taught to use the most minimally invasive approach, which was traditionally vaginal surgery.
What's your thought about that, vaginal versus?
So we feel a little differently about it. A vaginal approach, you're doing a total hysterectomy. You're not preserving the cervix that way. You can still remove even a bigger uterus vaginally. It just takes more time. So I was taught, that really is the best approach, but Dr. Shakiba feels differently.
Look, obviously based on American College of Obstetrics and Gynecology guideline, I believe still vaginal hysterectomy is the least invasive based on cost, and there is no incision in your belly, so some people like it. But as I said, the long-term result, first of all, with vaginal hysterectomy, you have to remove cervix, and you have less visibility when you're operating inside the vaginal canal. So I deal with mostly pelvic pain and pelvic reconstructive surgery. So for pelvic pain, you really want to see what else is going on. So having a camera there is definitely advantageous. And we talked about preserving cervix. What is the advantage of that? So that's the reason I don't like vaginal approach, because it's not applicable for many of my patients. I personally have done many vaginal hysterectomy, many laparoscopy, so I can compare all of them because I've done all of this. So to me, especially for the indication I mentioned, there's no question going robotically with and preserving cervix is beneficial unless there is a contraindication for it.
Yeah, definitely both approaches better than an open hysterectomy. And then from there, if it's just a straight hysterectomy, there's no pain related, maybe a vaginal hysterectomy can still be considered.
Whenever I book a patient for hysterectomy and I tell them I'm gonna keep your ovary, they often ask me, where is this ovary gonna be attached to? Is it gonna be floating? What's gonna happen to the ovary?
There's structures that support all of these reproductive organs. So the ovaries are attached to the side walls, partly attached to uterus, and then the uterus is held up in place with different ligaments as well. So when we cut all these ligaments, we're removing the uterus and the tubes. The ovaries, they remain attached to the side walls, so they're not just floating around in the body. They're still attached there.
Correct. So basically, ovary independently can be attached to the pelvic side wall and have its own blood flow and and also ovarian nerve remain intact. So the ovary continue to ovulate and function regardless, and not going to be floating in the pelvis. So.
Yeah, even without the uterus. On a similar note, actually, people ask me, when the uterus is removed, is there just an empty space in the body? What's gonna fill that space?
Well, the normal size of a uterus, I often say, is kind of, if you make a fist, is approximately size of your fist. By removing that from the pelvic area, remember the pelvic and abdominal cavity is a very busy space. Immediately that space is going to be filled with the loop of bowel, so it's not going to be a vacuum. It's not a designed space for the uterus that when you remove it, it's going to stay empty. So anatomy is going to restore its normal shape immediately. On the case of a very big fibroid, when patient have a fibroid uterus, obviously those big tumor is a problem. So when you remove it, then that compression effect of the tumor, which is abnormal and problem, will be removed. So therefore the anatomy can breathe and restore the normal anatomy. Again, it's not going to be a vacuum there that stay empty.
Yeah, and those patients with the big uterus, they definitely feel better and they feel a difference.
Yeah. Many people think when they get hysterectomy, they have a hormonal issue. Let's just talk about that. What do you think? Yeah,
there's a common misconception about this. People think if they have their uterus removed, they're going to go through menopause, which is not true. Just removing the uterus doesn't affect your hormones. They're not going to bleed anymore because they don't have a uterus, but they're not going through menopause because they still have their ovaries, and the ovaries are what makes hormones. Really, the uterus is, for carrying a pregnancy. Beyond that, it's not making hormones, it's not doing much more.
Very common question patient asks, how about in their sexual life or anything to do with their sexual activity?
This is something that a lot of patients worry about, and we hear this, almost every time that it's brought up. But, really studies show that there's not changes in your sexual function, desire, anything like that, just from removing the uterus.
Often patients who come and need hysterectomy actually are the one that their uterus have a problem or is a part of problem, including in the sexual life. So that means it either have inflammation in the uterus, which is called adenomyosis, that make the uterus very tender. And therefore, part of pain with intercourse come from that painful uterus. So the uterus in these kind of case is a part of problem. So therefore, removal of the uterus, it actually improves the sexual life on the patient who have a problem.
Yeah, it can actually help.
Yeah, so if the uterus have no problem, nobody want to go and remove it to begin with. So therefore, the question is a sick uterus or inflamed uterus versus not having the uterus, which one is better for sexual life? The answer is clearly not having that uterus would help on sexual life.
Yeah, and that's why it's such an important conversation to have with your doctor, because everybody's different and care is always personalized to what's going on.
There is a myth or common practice that whoever has pain, we should remove the cervix and the ovary to have the best outcome. What do you think about that?
So I think this was the thought around endometriosis for a long time, that because endometriosis is considered a hormonal problem and hormones are coming from the ovaries, that if you're doing, what we call definitive surgery or complete surgery, you're removing everything, the ovaries, the uterus, the cervix. But, that really, there's newer studies that show that really isn't true. You don't need to remove all those organs, and in some cases you don't need to remove the uterus. It depends what the patient's long-term fertility plans are.
Yeah, so again, that we have on our other video, that the origin of pain really is on the inflammation affecting the nerve. Again, sometimes the uterus itself is involved, which we call it adenomyosis. On those cases, if patient is done having pregnancy, having another baby, partial hysterectomy would be my way of going. I like to keep the cervix even on patient with chronic pelvic pain. No question about the ovary. I would definitely preserve the ovary because removal of ovary really not going to help this patient with pelvic pain, despite of very, very common practice, unfortunately, among many of our gynecologist colleagues. But I definitely, any patient watching this video, I would advise, if you are heading for surgery and someone want to remove your ovary, or is in your thought process that the ovary should be removed, give it a second thought, have a second opinion, get a third opinion. That's not a light decision to make, and make sure someone with updated knowledge about pelvic pain be consulted. And then if everybody agree that those ovary need to be removed, it's fine. About the patient after menopause, again, that's another topic. If it's a very early menopause, I still like to keep the ovary, because ovary still have some hormonal function up to 5 to even 10 years after menopause. But again, that depends on clinical scenario. I would definitely let your gynecologist or to decide if it's indicated to remove the ovary. Again, we're talking about benign condition, and if there is any cancer or precancerous business is involved in this is a totally different topic, okay?
And then regarding the cervix, our general practice here is to do a partial hysterectomy or supracervical. So even in these patients with chronic pelvic pain, we're leaving the cervix, and we're not seeing that they have more pain than patients who've had a total hysterectomy. What about in patients who have prolapse? We often like to blame the uterus, but the uterus is not responsible for prolapse. It's really all the muscles and the ligaments in the pelvis.
So some studies, some publications said the hysterectomy have a role on prolapse. What do you think?
So in those studies, they're losing, or they're cutting some of the ligaments that are important to support the vagina from prolapsing. So when you're doing a hysterectomy to prevent prolapse in the future, you actually will support those ligaments or suture them.
Yeah.
And that is more, we're talking about the total hysterectomy.
So what do you answer to the patient? Does hysterectomy would cause prolapse given those study, or what's the challenge here?
So no, when it's done correctly, if you're doing a total hysterectomy and you're providing that additional support during the surgery, then no, we don't see prolapse.
The notion that any hysterectomy would lead to prolapse is wrong. Most of patients actually have a bladder prolapse or uterine prolapse. They still have their uterus, so they come with complaint of prolapse, and they still have a uterus. So take-home message is uterus and intact uterus is not protective against the prolapse.
So on the other side of that, if you are doing prolapse repair surgery, do you need to remove the uterus?
Depend on what kind of surgery you do. There are many ways of correction of prolapse. For the transabdominal approach, which is to me is a better approach for correction of prolapse, I like to remove part of the uterus because it's in my way, and then I'm using a mesh to lift the bladder and cervix. And I feel it's not necessary to leave the uterus there. God forbid down the road patient have abnormal spotting, postmenopausal bleeding. It's going to be a trouble for next surgeon to go and remove that precancerous uterus among all this mesh and everything. So and also for correction of the prolapse, I definitely feel is better to get uterus out of the way, so we have more room for suspension to this sacrum, sacral promontory. So I do recommend from removal of part of the uterus and keeping the cervix on the prolapse patient when I do trans-abdominal approach.
And like we were saying, in a patient who is postmenopausal or a patient who's no longer planning pregnancy in the future, then the uterus is not providing much benefit anymore.
Yeah, again, I mean, there are urogynecologists that they disagree with me and they say I want to keep the uterus, but the question is what's the use of that uterus anyway? Removing uterus, to be all honest, take 20 minutes, 15 minutes to do the way we do it in minimally invasive is almost zero blood loss. So not really adding much to the length of surgery, but is much more complete surgery. And if someone tell me like a postmenopausal woman, what's the benefit of keeping the uterus? I may agree, but I don't see any benefit of keeping other than possible trouble down the road. So therefore, I do recommend on trans-abdominal correction, removing the uterus. It is very important to note that the content of this video should not lead you to have any medical decision on your own based on what we're saying. Every single medical condition needs to be evaluated with your own doctor.
Thank you for joining us for our discussion. Hopefully you did find it informative. You can leave your comments down below. We'll answer any questions that you have.
Thank you.